Committee will come to order. I always appreciate working with my distinguished ranking member, Senator Grassley, but I want to also recognize the Chairman of the Finance Committee, Ron Wyden, who is here, because the topic today of finding savings in our bloated and disorganized healthcare system is one on which he has dedicated a lot of attention and interest in the Finance Committee. And the Finance Committee has the legislative authority. I can have hearings, but he writes bills. So I'm particularly grateful that Senator Chairman Wyden is here today. I welcome our witnesses. Our hearing today will examine administrative cost in healthcare, how that cost harms patients and providers, and how much that increases federal healthcare cost overall. There is a lot of non-clinical work incidental to the actual delivery of care, and much of it relates to getting paid. Our hearing last October spotlighted a dizzying web of administrative functions costing over $500 billion per year. And of course, this is not just a matter of dollars and cents, even in the trillions. Actual lives are at stake. One of my constituents, Deb from Cumberland, faced cruel insurance hurdles in the wake of a brain tumor diagnosis. She said, "If fighting this disease wasn't enough to deal with, I and others are constantly fighting with insurance companies who are trying to deny every treatment path. For some reason, they feel that they know what's better for us than the medical community." For as long as I've served in the Senate, we've been discussing how to untangle this web of administrative cost burdens. As we worked on the Affordable Care Act, I highlighted how the broken economics of the healthcare system drove these administrative costs. The ACA made some strides in alleviating administrative burdens in the healthcare financial transaction ecosystem. Specifically, we set forth standard operating rules for electronic funds transfers and standardization of claims forms, producing less friction in the exchange of information between providers and insurers and facilitating faster care delivery for patients. But there is much, much more to do. Billing and insurance-related costs still total nearly $200 billion a year. The lack of standardization has been one major pain point. Different insurers apply different processes and rules to different providers, creating a web of confusion, driving up costs, and making doctors sometimes spend more time on administration than on providing actual care. The inconsistent paperwork required by different insurance companies makes it impossible to fully automate claims processing, resulting in thousands of lost hours, filling out forms, raising costs, and sometimes delaying care. In some cases, the costs of chasing payment for services rendered exceeds the payment for those services. Yes, it sometimes makes more financial sense to just give up and provide the care without seeking payment. There are several layers to the billing cost problem, but they mostly all relate back to an antiquated and defective fee-for-service payment model. That's why my recent bipartisan primary care discussion draft establishes value-based payments, at least for primary care, reducing reliance on fee-for-service payments and eliminating billing and associated administrative costs altogether for certain services. One particular scourge for patients is prior authorization. Confusing, cumbersome, and inconsistent insurance rules that stop care, while providers have to spend valuable time documenting and justifying the clinical need for a medicine or a service. In a value-based system, where doctors make their money by reducing costs and keeping patients healthier, there is no logic to prior authorization. So I propose that companies in Medicare get prior authorization from CMS before they're allowed to impose prior authorization on doctors practicing in successful accountable care organizations. A 2022 Surgeon General Advisory Report links administrative burdens with healthcare burnout, with less clinician time with patients, and even with harm to patients. The Surgeon General specifically called on insurers to, and I'm quoting him here, reduce requirements for prior authorizations, streamline paperwork requirements, and develop simplified common billing forms. When the Surgeon General is focusing on administration, you know it's long past time. My reform legislation will require the Centers for Medicare and Medicaid Services first to identify the worst prior authorization practices in Medicare Advantage. Second, it requires CMS to set common standards for common prior authorization requirements across insurance plans. Third, it will lift the prior authorization burden completely off providers and accountable care organizations with a proven track record of efficient patient care. No prior authorizations without prior authorization. I doubt insurers will be able to justify prior authorization for value-based providers whose incentives align with theirs. Providers may well have an incentive to run up their charges in a fee-for-service model, but running up charges is self-defeating for ACOs. In today's hearing, we'll discuss these and other solutions. We'll hear from health economist David Cutler how administrative costs in the U.S. are far higher than in other countries and where savings can be found in the healthcare financial transaction ecosystem. We'll hear from Rhode Island's Noah Benedict, who leads one of our state's highest performing primary care practices, the Integra ACO, which, by the way, is a national as well as a Rhode Island leader, on how administrative burdens hurt his ACO patients. As I have said many times during hearings of this committee, my focus is clear. Let's work on serious proposals that reduce healthcare spending with zero benefit cuts. Such proposals are good for patients, good for doctors, and good for the budget. As I turn to my ranking member, I'd like to thank Senator Grassley and his team for showing up at my healthcare savings office hours with several very helpful and promising ideas and suggestions. Senator Grassley, I look forward to working with you, and the floor is yours.
We had a pretty quiet meeting that day, didn't we?
Well, there was just us kids, but it was a good meeting.
Yeah, you bet. Well, I want to thank you for following through on this hearing today, and reducing administrative burdens in healthcare is a very important and top priority issue. Our country spends more than $4.5 trillion annually on healthcare. Our spending has more than tripled as a percentage of gross domestic product since 1960. Growing healthcare costs don't just strain Americans' pocketbooks. These healthcare costs also are a major driver of widening budget deficits and the federal government's unsustainable fiscal outlook, and we're not getting our money's worth for all of our spending. Major healthcare program spending eats up 32% of the federal revenue today, and it will be 44% by mid-century. Our healthcare system has plenty of waste and inefficiency, and these ought to be fixed. As I've stated in our previous healthcare-related hearings, we should begin by increasing transparency, competition, fighting fraud, and cutting red tape. Federal regulations are often too burdensome for physicians and healthcare providers. We should promote innovation and competition under Medicare and lessen the focus on central planning. Since 2021, federal agencies have imposed over 90 regulations on the healthcare industry, costing taxpayers and providers over $100 billion. These regulations create 10 million hours of paperwork, hours that could be better spent providing care to patients. This is the opposite of reducing the administrative burden. I'm glad that the Centers for Medicare and Medicaid Services recently took action to improve the timeliness of prior authorizations for seniors that are on Medicare Advantage. I hope this lessens the burdens on providers and improves access for patients. I support putting more sunshine on prior authorizations. CMS should be aggressively auditing Medicare Advantage prior authorization activities so that we have a clearer understanding how the patient, providers, and taxpayers are impacted. Some administrative functions serve an important purpose in preventing unnecessary healthcare spending. The Government Accountability Office and CMS across multiple presidential administrations have created and agreed that transparency and efficient prior authorization plays an important role in combating waste, fraud, and abuse. Cutting down on $103 billion of improper payments for major healthcare programs would be an effective way to lower healthcare spending as well. I'm the author of major and more recent updates to the federal government's most powerful tool in fighting fraud, and that tool is the False Claims Act. Since the enactment of these reforms, the federal government has recovered more than $75 billion lost in fraud and actually saved billions more by deterring would-be fraudsters. In 2023, there was more than $2.7 billion in False Claim Act settlements and judgments, with $1.8 billion of that $2.7 billion involving healthcare industry. Now, we all know that whistleblowers are very responsible for helping recover nearly all of this money that's been recovered. The Justice Department, CMS, needs to be more aggressively going after healthcare fraud, waste, and abuse. We can reduce administrative burdens in healthcare for providers and patients without compromising access to high-quality care. We can get there by reducing regulations while maintaining guardrails to protect patient-centered safety and quality. Through greater competition and transparency in our healthcare systems, we'll help to bring down costs and lessen administrative burdens. Healthcare spending can be made more efficient without compromising the quality of care or reducing access, especially in rural America. I look forward to hearing from our witnesses today on ways that we can reduce administrative burden in healthcare for patients and providers while lowering taxpayers' costs. Finally, I want to comment on a recent Medicare trustee report. Medicare is part of America's social fabric, and for decades it has provided seniors with disabilities access to routine and life-saving care at their local hospital, doctor's office, and pharmacy. For the 8th year in a row, the trustees have issued a funding warning because Medicare outlays are expected to exceed its dedicated revenue by 45%. Republicans want to preserve and strengthen this program for future generations. The only way to make these critical programs sustainable is to follow the Ronald Reagan Tip O'Neill model of 1983. That means that Congress and the President working in a bipartisan fashion is what it takes to get the job done. I'm proud to have been led the effort in 2003 to modernize Medicare by establishing the prescription drug benefit, Part D. In the first decade of Medicare Part D, the federal government spent 36% less than projected, while improving access to prescription drugs for millions of seniors. That effort required bipartisan cooperation from both chambers and presidential leadership, and is a prime example of what we need to do to address Medicare's fiscal challenge. Thank you, Mr. Chairman.
Thank you very much. We'll turn to the witnesses now. We'll first hear from Professor David Cutler, the Otto Eckstein Professor of Applied Economics at the Harvard Department of Economics, with secondary appointments at the Kennedy School and the School of Public Health. He's also a member of the National Academy of Medicine. He's researched and written about the costs of medical care, including administrative costs, and advises businesses, governments, and healthcare providers. We'll hear then from Noah Benedict. Mr. Benedict is the president and CEO of Rhode Island Primary Care Physicians Corporation, the largest multi-specialty independent practice association in Rhode Island, representing 168 primary care providers and over 300 specialty providers. Rhode Island Primary Care manages care for over 200,000 lives and stands at the forefront of healthcare delivery in our region. Mr. Benedict is also one of the principal architects of and serves as vice chair on the board of Integra, one of Rhode Island's highest performing ACOs. We've heard regularly from them in various committees. His rival at Coastal Medical, Al Kuros, has been a frequent witness, and the competition between Integra and Coastal has been for national preeminence, not just local preeminence. Mr. Benedict also serves on the boards of the Care Transformation Collaborative of Rhode Island, the Kodak Behavioral Health Care Group, South County Health, the Rhode Island Quality Institute, and Horizon Healthcare Partners. Our final witness will be Dr. Anthony DiGiorgio. Dr. DiGiorgio is an assistant professor in the Department of Neurological Surgery at the University of California, San Francisco. He cares for patients with traumatic brain and spinal cord injuries. He's also director of spinal neurotrauma at the Zuckerberg San Francisco General Hospital and Trauma Center, a county-run safety net hospital. Gentlemen, each of your full statements will be made a part of the record without objection. You have 5 minutes, and I will give notice that at the conclusion of your testimony, I'm swapping my spot to ask questions with Chairman Wyden. He has other business to get to, so the order will be Wyden, Grassley, Whitehouse, not Whitehouse, Grassley, Wyden. Please proceed from a fee-for-service model to a value-based model. You nevertheless still had to keep track of the whole fee-for-service system, and that's still the case.
That is still the case because
So
not
would it
every-
be better, Dr. Cutler, if we move to a more robust hybrid payment model so that the tracking through fee-for-service could be lifted in addition to the billing through fee-for-service?
In many cases, there's no reason to do that tracking because they're the ones who are bearing the risk. And so documenting all of it that way is really just a waste.
And I was interested in the comments that I think you all seem to agree on about cleaning up electronic medical records. Mr. Benedict serves on the board of Rhode Island Quality Institute, which is a group that I founded years ago as Attorney General in the wake of the crossing the quality chasm into ERA's human reports and all of that. And we focused a lot on first health information technology, then health information exchange, and we've been pretty robust in all of that. So it's disappointing to me to hear that that technology is now the vector for more trouble than it's worth. And I was struck by Dr. Giorgio's comment that his clinical care improves when the EMR system goes down. So my time is up, but I would very much appreciate it if in the same way you'll do a written response by QFR on the question of how we negotiate the superabundance of quality measures problem, with any advice you have on trying to figure out how we solve the problem of the health information exchange, which was intended to be a beautiful thing. Thank you. With that, the next, Senator Johnson is next up, then Senator KAINE, then Senator Marshall.
Thank you, Mr. Chairman. Appreciate this hearing. Again, it's similar to others we've had where, we're talking about putting a Band-Aid on a dying patient. And so I want to talk a little bit about the root cause. Dr. Cutler is an economist. What would happen if, let's say, buying a car was an entitlement and there were no regulations on what kind of car you would buy? What would the American people do? They'd go out and buy the most expensive car possible, right? Right.
Or expensive cars.
So you'd end up having then put regulations. You need certain, if you want this kind of truck. Well, that's what's happened in healthcare. Mr. or Dr. DiGiorgio, whatever, doctor. Sorry, I'm terrible at that. You mentioned excess federal regulation. You said regulatory burdens, Medicare billing requirements. CMS creates a floor. We need increased competition. None of the things we're talking about increases competition. None of the things we're talking about actually reduces regulation. So the root cause of all of this is a third-party payer system. Mr. Benedict, why do independent physicians need to associate with your association? Why do they think they need that?
Without the scaffolding we can provide around them that helps them ease the administrative burden.
It's all about you wouldn't be necessary if it weren't for all these administrative burdens caused by a third-party payer system, really driven by government-run healthcare. So as long as we got this massive government-run healthcare third-party payer system that, I mean, you're not going to change government. You can talk about fee-for-service going to a value-based model. Again, those are just buzzwords. It's not going to reduce the regulatory burden, just like the EMS didn't really fix the paper burden. It made it worse, or it certainly didn't make any improvement. So why aren't we talking about transitioning to something that actually would increase regulation? Why aren't we talking about high deductible insurance plans that cover the catastrophic events and then bring consumers back into the process? I mean, isn't that the real solution? I mean, I don't, Dr. Cutler, what other area of our economy are people participating in that part burning out because of administrative burdens? Not that there aren't administrative burdens in other areas of our economy, but this is kind of unique to healthcare, right?
It is unique to healthcare. It's also the case, while I share many of your sentiments, unfortunately, many people don't use their high deductible health plan in the appropriate way either.
Well, because we don't require them to. The only, in many healthcare plans, the only deductibles ever paid is like a $10 copay. So again, people don't really care about the cost of the drugs. I mean, again, we have taken the benefit of free market competition out of healthcare. And that's the problem we're dealing with. So again, anything else we're talking about here literally is putting a Band-Aid on a dying patient. I'd like to revive the patient. So I'm seeing a lot of heads agreeing with me. Where's...
I would say the only caveat there would be you could globally attack this issue with value-based approach to contracting, namely global capitation or risk, because then you actually change behavior. There is responsibility for the costs associated with the care delivered.
But wouldn't you be better off with independent physicians doing that themselves, or a lot more different insurance companies where you actually had true competition? Mr. Benning, you mentioned the word the market. Where's there a market in healthcare, truthfully?
It's local.
It doesn't really exist. I mean, we have a complete failure of a marketplace here. We've got government control, by and large, setting the terms for how the insurance companies operate. And the only thing they've come up in terms of restraining costs are pre-certifications, and we see the damage done by that. But what else is there to control costs? So you're suggesting doing away with that, then Katie barred the door in terms of runaway costs. I mean, what is the current dollar value in terms of how much more Americans spend for healthcare versus other countries in the world? But we at least double, right?
Multiples more.
So it's completely broken. So again, why aren't we looking at the root cause of this as opposed to, again, these buzzword solutions that I just don't think would actually work? I mean, I know it's an attempt within a system that's probably going to be impossible to change.
I would only retort, that's really tearing out the entire chassis, and that may be necessary, but along the way, for us to control those costs, there are opportunities for us.
So one final point. In Wisconsin, I think this is occurring, there are doctors who are just dropping out of the system, not taking Medicare and Medicaid patients, and just literally charging cash. And it's unbelievable how first of all, cost-effective it is, like $55 for a half-hour visit, and the doctors love it. I think we ought to start figuring out a way to transition that where doctors are at the top of the treatment pyramid rather than being crushed at the very bottom and become independent again, like it was only a few decades ago. Thank you, Mr. Chairman.
Senator KAINE.
Thank you, Mr. Chair. When Senator Johnson started off and said that the problem was the third-party payer system, I thought he was going to go full Bernie on me there for a minute. I was intrigued with the opening. This is a great hearing and great witnesses. So just a couple of questions. So Dr. Cutler, your chart, which I was intrigued by. So you believe just implementing, basic technology reforms, efficiencies, and improvements could save us about $130 billion a year. And that's just administrative improvements. Senator Marshall and I are on the HELP committee together, and he and I have been working really hard on PBM reform. We've got a good PBM reform bill out of the committee on the floor of the Senate. I think it was with an 18-3 vote. We're waiting for hopefully getting some floor time on that. That's a big saver too, and that's not necessarily administrative, but it's just going at a piece of the system in this weird complexity that we have, where we've got a middleman sucking up huge profits who do no research and produce nothing. I mean, they were designed, I guess, to try to control somewhat what pharmaceuticals people were getting, and instead they often are blocking access to lower cost pharmaceuticals because they collect a percentage price of what they're providing to patients. And so if it's $130 billion we could save just by dealing with administrative efficiencies, Dr. Cutler, do you do any work on kind of where the just excess slosh and profit is, that if we were a little more efficient and took that out, what we might save?
So I think as a whole, the country could save close to half of medical spending, let's call it between a third and a half of medical spending, which I think, as we were talking about earlier, would be enough for tens of thousands of dollars per American family. Some of that is on the administrative end. Some of that is on things like prices that are way too high, pharmaceutical prices that are higher than they need to be in the U.S. and elsewhere. Some of it's profit, like, for example, in pharmaceutical companies. But, for example, most hospitals and physician groups are not earning high profit.
Yeah.
Where the money is going is it's going to the administrative stuff and to all the other aspects of running things. So it's almost like the worst of everything, because it's not even that someone is benefiting from that money. It's just that we're employing all these people to do stuff that's not contributing to our health, in many ways harming it.
I want to ask Mr. Benedict, you talked about this physician burnout phenomenon. I have worked with colleagues to pass a bill that we're working to reauthorize now, called the Lauren and Breen Healthcare Provider Protection Act, which is named after an emergency room physician who sadly died by suicide in the beginning phases of COVID, who was working in a hospital in New York, got COVID, sat out for 2 weeks, came back too quickly. Her last publication, she was a very well-published physician. Her last publication before she died was on physician burnout. Now, there was a unique burnout during COVID because of the scale of death and injury, but her published work talks about the very phenomenon that you guys were describing, which is, hey, I did this because I want to work with patients. I don't want to be just endlessly inputting information. And I think as we look at provider shortages, and particularly in some areas like behavioral health or rural America shortages, they're going to get more acute unless we solve this problem. So I really appreciate you bringing up the physician burnout piece. When 3 of the 4 categories of pressures that create this burnout phenomenon are kind of tied to the reason for the hearing, that should make us have a sense of urgency about it. And then, Dr. Giorgio, I wanted to drill down on something you said. You said, and I was not quick enough to write it down and follow it, but you said you might hope that we could equalize maybe Medicare fee-for-service, Medicare Advantage reimbursement rates, and then you said something about quality rating system.